Hey everyone, and welcome back to the Information Bottleneck podcast. And today we have a really great guest, Kyunghyun. He's a Glendy various professor of health statistics and in general professor for computer science and data science at New York University. Hey,
Hi, thanks for the invitation.
thank you for coming. And as always, we have Ellen. Hey, Ellen.
Good to see both of you, and I'm back in North America again, and I have so many questions. This is such a special guest, and one who's right up there, with obviously nobody's quite Ian LeCun, right? But we're
No,
getting close again, thank goodness. So this is a very, very dignified praise that I'm trying to put here.
thank you.
Yeah, so today we are going to talk about so many topics because you're doing so many things. So I think we can start with healthcare. I think this is such an important topic and so timely. So yeah, let's start. Like, how do you see the field? There are so many um changes in LLMs, in AI, like right, like every
Mhm.
day we have something that Anthropic tries to
Yes.
beat and to go to insert to this field. How do you
Mhm.
see it in healthcare? Do you see that this phenomena also apply for healthcare? Do you see that like we are already there, or like we are getting closer to be dominated by LLM, or do you see
Uh-huh.
something else?
Yeah, I'm actually very happy to see that the many of these kind of so-called frontier labs, as well as the scientists in frontier labs, are thinking about this major issue called healthcare in our society. Because healthcare is something that is very unique. It's unlike any other industry sectors that we imagine in our head. Because healthcare is something that we cannot opt out. So almost everyone in this modern society is born inside healthcare. So even if you're born at home, often there are midwives. Midwives are all clinicians, they're part of the healthcare. And then eventually everyone dies within healthcare as well. In fact, the death certificate is issued by the clinicians, and then they are all healthcare professionals as well. Now, what that means is that this is not the thing that we can just approach it by simply saying that, well, here's a in the industry sector, we're going to just revolutionize it. Because one small change is going to affect everyone on the society. So we have to be very careful. But because of that, it's very difficult to change anything. And then in order for us to actually change anything from it, we have to approach it extremely seriously. And then I see, the OpenAI, the Anthropic joining actually makes people think about healthcare a lot. And then I think that that's already the great first step. Now, unfortunately, healthcare, because of this kind of conservative nature of healthcare, we can't really change any single aspect of the healthcare that easily. I've worked on drug discovery at Genentech for the past 5 years, and then even drug discovery, which is a small part of the overall healthcare, still could not be changed that easily. Although we have amazing AI system for drug discovery or the molecular design, those things are just tackling the tiniest possible part of the healthcare. And then when you have this kind of large system, there's always a question of, will this large system change if we start changing one, let's say, not better time? Seems like that's a very difficult thing. But at least we now we now have started to actually look at the whole thing. And then hopefully we'll be able to change it sometime soon. As in, how do we actually think about the healthcare from scratch using these new technologies like AI? So I can actually give you one example how I think about it is that there is a weird thing. You probably have noticed if you've ever been to clinics or the hospitals, or even if your families have been there, it's the fact that the hospitals maintain patient records. And if you think about it, patient records are, of course, legally as well as inherently your own, like the patient's own. And then nowadays, everyone actually carries multiple devices that have like gigabytes of the memory, and that we all have access to the cloud. And then we have another, let's say, tens of gigabytes of the storage in the cloud as well. But somehow we never maintain our own patient record. Patient record is somehow always maintained at a hospital in the case of the US, or across the different countries, you have some centralized organization, either government driven or whatnot. Now, this is a really big question I started to have is that why is that the case? In fact, this is a really weird thing. If you think about one more thing, that is that we have to ask hospitals for our medical records. And then sometimes hospitals can also delay it or not even answer our requests as well. And then that's where everything becomes weird. But if you think about the historical context, it's not weird at all. Why is that the case? Because record keeping has never been that easy. So individuals were not able to easily and safely secure a paper-based record at their places. They would move around, they would lose it. If there's a fire, everything goes away. And thereby, doctors were maintaining the records of their patients on behalf of those patients. Now, of course, times has changed, but somehow the system has not changed at all. And then this actually brings up a lot of the issues here as well. Because I don't own and bring my own patient record, every time I go to a new hospital, new doctor, new clinic, or if I move to another country, then everything starts from scratch. I can, of course, bring my own records, but how often do we actually do that? We just start from scratch. And then what that means is that all the information about myself or any of the patient is always fragmented across the multiple hospital, multiple clinics, and even multiple countries as well. And then these things are all kind of things that we cannot simply change overnight because obviously we have to ensure that everyone still maintains their patient record without having to spend too much of the effort because we need to make it happen for everyone in the society. But then it has to happen somehow. So there are a lot of, let's say, complications and the things that we think we can do much better with the more recent technologies and also the future technologies like AI. But it will take some time. And then that's the reason why I actually welcome, let's say, OpenAI, Anthropic, Microsoft, and all those big companies, along with the amazing research hospitals, to work on this more so than before.
But I have a question. Like, it looks that for sharing information, you don't need these sophisticated AI systems, right? Like, you can just, like, I don't know, do some regulation that, like, you have some general, like,
Hmm.
main system, right? For example, in Israel, right? Like, there is a system that shared between hospitals and like some clinics,
Hmm.
and every doctor can if you give it permission, if you give them permission, it can access to your records, right? Like, you don't need all
Absolutely.
these things. So
Hmm.
do you think that,
You're
like, this is
absolutely
it
correct.
will it will make it easier, or do you think this is just one step in the way to get to the
You're
real?
absolutely correct. In fact, what would we really want is that the everything is maintained by us, right? Directly. Of course, it's going to be outsourced to some of these companies, right? So maybe Google is going to provide this kind of personal health record, let's say management, let's say service, or Apple may do that. Apple is doing that already to a certain degree with the Apple Health. What we want is that we go to the healthcare providers and then we're going to literally tap our phone and then give them the access to it for 6 months. But the nice thing is that the doctor that I gave the access to will have the full record of me. And then history of the patient as well as the family history are two most important things in order to make the proper diagnosis as well as the treatment. Thereby, it's going to actually improve the quality of healthcare so much greater. An interesting thing is that this is going to happen eventually, but this actually requires us to change the entire backend of the healthcare that involves not only the medical records of the patients themselves, but also the billing information. Who's actually going to pay for it? Because this connects to this earlier discussion we had about the inability to opt out. Because no one can opt out, healthcare, everyone is paying for everyone else. And then thereby, we have to actually keep track of it really carefully and always convince everyone else that they need to pay for my healthcare. And then this makes it really, really complicated. So how are you going to update that? That's actually going to be yet another thing that needs to change quite dramatically.
So, I should have probably asked this right before we started the recording because I don't
Okay.
know. So obviously, you spoke about like trying to do work in Korea, and so I don't know like your citizenship status. The reason I'm trying is for when you're talking about healthcare, this as an American, this is the
Yeah.
most like American problem ever. But I also
Right.
know that the history, especially of modern Korea, is
Hmm.
highly, I will just say it was easy as an American to do things there. I felt like a very America brought a lot of things, possibly a more privatized healthcare system. And so I guess, first of all, please correct me if anything I've said is wrong in that analysis. But can you give any like differences between Korea's healthcare system and the US's in the context of like the AI question and all of these, if you know those questions well?
Yeah, Mehdi, I have some thoughts, of course. I don't know too much about all those things. I am a dual citizen, so I'm a Korean and also American. And then I was born and raised in Korea, so I experienced the healthcare in Korea. And also I've been here now more than 10 years, so I've experienced a lot in US system as well. Now, of course, fortunately, I'm a faculty member at NYU, which also has its own medical school that gives us a kind of, let's say, a bit more superpower than many other people. So that's been a privilege that I've enjoyed. But then, of course, the healthcare system is very, very different. In fact, the Korean healthcare system is more in line with the every other country's, let's say, healthcare system that is highly, highly centralized. On the other hand, U.S. healthcare system, we all know that it's extremely, extremely decentralized. And then, of course, it's easy to think of it as a public versus private or the single payer versus a multiple payers. But I think it's actually more correct to think about it as a centralized versus decentralized, because you can actually have a publicly mandated decentralized healthcare system as well. In fact, it doesn't have to be fully centralized. Meanwhile, there can be a centralized private version as well. So what is the main difference is that a lot of what the doctors can do to the patients, and then what are the things that are going to be covered by the insurances are going to be determined extremely carefully, and that is centralized in Korea as well as in many other countries. In US, there are a lot of, let's say, rules, and of course, the insurance companies, together with the Medicaid and Medicare, which are in fact the largest, let's say, payers in US as well, they will determine what are going to be covered, but it's relatively decentralized. You can always find the new insurance companies, or you can also decide to simply pay yourself for all those treatments you can, even if the insurance companies do not cover in US. And then this actually makes it a really interesting case in the sense that there's a much more kind of incentive as an encouragement in US to try things that are much more at the frontier, much more rapidly. That, of course, is the reason why there is a lot of progresses, both in terms of the generic healthcare as well as AI for healthcare in US. But also, it turned out that the centralized versions, just like in Korea, has a distinct advantage is that the data that drives a lot of the innovations in AI are indeed actually contained and stored in a one place where once the researchers can have access to, they can really look at the entire country's records and then try to build the systems that can tackle the address issues that actually exist in the country. So it's a bit of a two sides of the same coin, because at the end of the day, it's still the same thing that the healthcare in every country has to cover everyone. No one really opts out. Even in US, it's kind of impossible for us to opt out of the healthcare system. But there is a kind of major difference there. So the interesting thing is that we have a global AI frontier lab that we created at NYU. That is a collaboration between NYU and Korean government. And then about 7 institutions from the Korea are participating in this lab. And we have 3 research teams. And third theme is AI for healthcare. For that one, NYU Langone researchers together with me are working together with the university hospitals from Korea together. And then that's where we learn a lot about the differences as well as the potential synergies that can be had.
So, okay, let's assume that we know that it's very complicated to collect the data and to merge it and to make it to unify it. But first of all, like what types of data do you actually want, or like you actually think it's useful? And then when you have this data, what you're going to do with that?
Yeah, that's a great question. So I don't think a lot of the data we have already collected, for instance, in healthcare, or we can even talk about the more narrowly for the patient data as well as the let's say for drug discovery, let's say molecular data, are as useful or as informative as people think they are. The reason being that many of these data sets were collected, or the data has been collected without the purposes that are aligned well with how we build AI systems. So for instance, I have this outrageous idea that I've been having over the past, let's say, 2-3 years. I wrote one blog post on my homepage, and then that actually made me hated by many of the doctors even more so than before. However, if I just repeat the content there here once more, is that a lot of the EHR data is somewhat useless for the purpose of, for instance, counterfactual or the causal inference. The reason being that there's almost no randomization that happens when you go to the hospitals. And then why is that? This is really a mystery to me, or it was a mystery to me, because there is always uncertainty. And when it comes to diagnosis as well as the treatment by the healthcare providers to patients, the level of the uncertainty is dramatic. In fact, almost nothing in healthcare, as far as I can tell, is certain. Even a particular disease, defining a disease
Do you
is
mean
a
about like
extremely difficult problem.
about the do you mean
Mhm.
like to diagnose like the specific disease, the specific
Mhm.
problem that
So in
you
fact,
have?
yeah, for everything you can imagine, yes. So let's think about the diagnosing a particular disease. For that to happen, we need to have a very clear definition of that particular disease. But we often don't have the definition of a disease. Disease is really just a cluster of symptoms. Unless it's a very particular infectious disease where we know the infectious agent, it's almost always just a cluster of symptoms. They often are not one disease as well. And then next thing, what do we need? We need to know about the patient. What kind of, let's say, patient am I looking at? It's really difficult to tell because we don't really have a full history of the patient. We don't have the family history. And the patients often don't share all the information with the doctors as well. There's a bit of a trust issue, right? And then that's a bit unique problem in US as well because of the history, modern history here. And then this all makes it impossible for any clinician to be able to make a 100% certain, let's say, diagnosis or even make a recommendation on the treatment. But then at the end of the day, what we would say as a machine learning researchers or the statisticians is that if there is uncertainty, then what should be done is that yes, they need to toss a coin and then choose the one that is according to this random number generator, as long as they are of a high probability. But unfortunately, that's not what happens. Let's say one clinician, they see, let's say 10 patients, and then let's say they all had the similar symptoms and then similar patient history and everything. And then say there was some uncertainty on the diagnosis. The doctor is going to give the same diagnosis to all of them. They're not going to toss a coin. And thereby, in fact, we have a huge amount of the selection bias here in our data. Thereby, this kind of data is not going to be that useful for the purpose of the causally, let's say, consistent, let's say, diagnosis generation or the diagnosis systems when we build them. So what that means is that the data is there. We have massive amount of data, patient data, all those. And then when it comes to patient data, all those images, lab measurements, prescriptions that have been given to them, treatments that have been given to them, and then sometimes even the records of what kind of things they've been eating, right? Diet histories and so on. All those things are there. But what we actually don't have as a well-controlled one is that what were the things that were given to them, and then what were the alternatives that were considered? We actually have no idea about it. So then what we can do, I think, is that we need to actually let both train and then force or encourage the clinicians to toss the coin. So what I have been suggesting is that for every time you go see a doctor or the clinicians, they're going to all write a note eventually. And then what we want them to do is that right before they make a diagnosis or write a prescription or come up with a treatment plan, we want them to write down at least 2 to 3 plausible diagnosis or plausible treatment plans on the screen. And then the system is going to choose one for them automatically. And then they just follow this one. And then there's an automated randomization happening. And then what that means is that we are running the clinical trial nonstop forever and ever.
But you have also like the problem of like precision and recall, right? This is not like a constant threshold, right? Like it may be that like for different people, you will need to put like different doctors will put the threshold in a different place.
You're absolutely correct. In fact, so the doctors don't put really the thresholds, so because they cannot really think about, they cannot come up with the proper distribution over the all possible diagnoses anyway. So we are using them as getting the top K, let's say, diagnosis, but among them we treat them as all equally equivalent, and then we're going to choose one uniformly for them. Now, this is a kind of a very difficult idea to chew and digest. I gotta say that's actually the case. But in some sense, in this way, we can actually run this kind of nonstop clinical trial at the society level. And then thereby the data that is collected will actually allow us to build a universal causal inference engine for healthcare. And I think that's the dream that we all have.
So I just want to intervene for a moment. This is a fascinating idea. I've never thought about this, by the way. And I also want to point out that it collapses the problem into a nearly identical one to LLM sampling, which, if
Mhm.
anybody that knows our podcast at least knows me, that is near and dear to my heart. And so you mentioned top K, but you can devise equivalents to MinP, for example, which
Yeah.
Ravid and I are on, where we say,
Mhm.
well, the predicted probability influences how many selection candidates we have, that also, when
Absolutely.
you start explaining more sophisticated forms of sampling using what you're doing, though, it becomes a lot easier for people to swallow that. Though top K will really encourage either some diversity or some weird
Uh,
behavior from doctors
right, right.
in the
Mhm.
system when they feel
Yeah.
really confident about, like,
Uh-huh.
but
Uh-huh.
I love this in the same way that I love taking some ideas about, like,
No,
civic
you're
society from
yes.
movies, like, or books like Starship Troopers too. It's almost an idea that seems like it would come from a movie or a book like that. So I just want to hear more. This is fascinating.
Yeah, and then you're absolutely correct. And then this actually connects to all those, like the basic fundamental concepts in machine learning, as you pointed out, right? So, in fact, if you go all the way down, at the end of the day, every learning problem can almost always can be written down as a reinforcement learning problem with some form of the reward function. But then what is the most challenging part there is that it's not the learning process itself. So fitting a parametric form of the function, I think we have actually figured it out over the past, let's say, 3 decades. We have the residual connection, we have attention, we have nowadays like it's a muon and all those amazing, let's say, stochastic optimizers and whatnot. So we figured that part out. But then the key is that one thing that we'll never be able to figure out, in my opinion, is how we do the exploration, because the exploration is inherently domain specific or the problem specific problem. There cannot be any arbitrary, let's say, exploration scheme that works, because I can always come up with the arbitrary reward function that's going to defeat the whole, let's say, exploration scheme. But then when it comes to this kind of healthcare, what is really interesting is that this is where, just like how the ChatGPT as well as all those conversational LLM has become, let's say, overnight sensation, is that everyone uses it and that everyone will use it. Thereby, the amount of the data that is created is massive. And then if we add this kind of a bit of sprinkle of the exploration on top of that, doing top P, mean P, or all those different sampling algorithms, and then get some kind of implicit feedback, that we suddenly have a massive amount of data that allows us to build a system that actually maximizes whatever the arbitrary reward we probably want to maximize down the road. But with the healthcare, we cannot do that at the moment, because all the clinicians actually swear to do best for each and every patient. Thereby, if they have a tiny suspicion, however miscalibrated it is, that the one diagnosis better for this patient, and then if they're the same patients over, they're going to go for the same diagnosis over and over. So currently the healthcare doesn't train the individuals within the healthcare system to think at a group level or at the society level. We are only thinking at an individual level. So changing that is going to give us a kind of, let's say, kind of data, I think, is going to bring us to the next level of the AI for healthcare, or the healthcare driven by AI.
I love it. I
Uh,
love it. This is
so,
fascinating to think about. Um,
so,
It's a bit
so first,
extreme. Sorry about that.
no. So like, okay. So like, what do you think is missing? Like, what do you think? What parts are missing in this for like
Yeah, I mean,
making this
in
happen?
healthcare. So maybe I don't have, maybe healthcare is a kind of, let's say, too big a chunk. So I'm going to talk a bit about the drug discovery and development, where I spent some more time on over the past 4.5 years at Genentech after, selling our prescient design. So what is difficult is that they say, I want to come up with a new drug. Usually what people are doing now is actually not to come up with the drug initially. They start thinking about the disease. What are the diseases that actually affect a lot of people, and then often may have a cause that is based on genetics? Because if there is an environmental cause, it's usually easier to fix the environment than come up with a new drug. So we want to actually try to do that one. So but there is a genetic cause, then we have to come up with a drug, because that's not the thing that we can fix by changing the environments. So then let's say we try to find some kind of genetic cause, and then we identify the target gene or the proteins. And then once we identify it, and if we think that that's the right gene or the target to design the drugs for, then we're going to design a molecule. Could be antibodies, could be small molecules, or different types of the modalities. And then we're going to choose one that we know are going to bind to some of the proteins that are in the pathway starting from the cause to the symptoms. Great, find it. And then we need to develop it further. We need to characterize how it's going to work within our body. And then we need to characterize the safety profiles because almost everything that we design is toxic. In fact, designing a toxic molecule is very easy. Everything is toxic to us. Nature is not friendly to us. So we have to make sure that it's actually safe for us. And then on and on. And then we're going to do some more testing before we ask the FDA for the clinical trial. And then we do the phase 1. And the phase 1 is where we check the actual safety, recruit the healthiest possible people, 40 to 50 of them. And then we're going to increase the dose until the point at which we see that, okay, there is no issue with the safety. And then this is the maximum dose we can go to. And then if we find that there is a dose, we go to phase 2. That's where we actually test the efficacy. And then on and on and on until the phase 3. And then we need to manufacture them. We need to build a factory and everything. Now, along this way, it takes about 5 to 10,000 people over 50 years up to. So starting from the beginning to the end. And then what that means is that no one can actually see the entire thing that easily. And then everyone needs to look at the individual stages only. And at each of the stages, they have perfected their art. They know what to do. They have the criteria they've been following. They know how to, check all those boxes. Now, unfortunately, just like what we are talking about in machine learning in 2006 to 2009, was the layer-wise pre-training. At the moment, every layer or the stages have been optimized on its own without actually taking into account what's going to happen later on. And then thereby, a lot of these stages have extremely low chance of being successful if you look at whether any one of the things that came out of the stage became the actual eventual therapeutics. That is because we're not thinking end to end. And then the same thing in healthcare as well is that a patient comes in, we look at the symptom, or the actual doctors look at the symptom, and then trying to come up with the best treatment plan. However, this actually takes into account that particular, let's say, incident for which the patient came to the hospital. We cannot really think about the much longer term. Can we think about the patients at the level of the birth to the death altogether? Or can we look at the drug discovery as can I come up with a molecule that's going to be eventually successful at the clinic, not passing this stage? We don't know. We haven't been able to do that because we don't know how to do that. And thereby, the whole system is somewhat fixed in this kind of old school, stage-wise, funnel-based paradigm. And then I think AI is here to actually get us out of this stage. And then that actually happened within machine learning itself, right? We're doing a feature engineering, feature selection, feed a linear model, and then hope that everything works well. And then later on, we went, okay, let's train a restricted Boltzmann machines over and over on top of each other to initialize the deep neural networks better. That was actually my PhD dissertation myself. But then eventually, what was a key thing to the success, just like what Jan did in his 80s, his PhD dissertation, just to end-to-end training. We know the loss. We need to update everything all together. And then the best way to ensure that what we build is going to achieve the goal that we want, rather than just making individual stages better and then hope for the best. So yeah, this kind of change of the conceptual change is going to be the first thing that needs to be done. Some people started to look into it, but not everyone yet.
But in healthcare, it's much more complicated, right? Like if you're when you have, I don't know, terminal bench 2, then that's fine. Like you break some code and you can try again and again, right? But in healthcare, it's much more complicated. First of all, it's life or death, right?
Absolutely.
And also it's very expensive. You need to collect people. Uh, the physical world is much more complicated. So how do you think we should
Yeah.
approach it?
Absolutely, absolutely. It's absolutely true that it's much more is at stake, right? With healthcare. Yeah, I think if the code actually breaks, or even when the AWS had a 13-hour long, let's say, outage, the world continued. But of course, healthcare, if you have some mistake that goes on for the 13 hours at ICU, then people will really die. So it is really much more serious. And then that's the reason why we have to be and then that's the reason why everything has been moving slowly. But also, we have to acknowledge, I think, that the healthcare or the drug discovery, especially drug discovery at the moment, is already at the stage of failing the whole society. Why is that? Because the success rate of inventing and approving new drugs is only going down, and then it's going down rapidly. What that means is that of course, Gary was, at the kind of say hammered because he said that the deep learning was hitting the wall many years ago, which was incorrect. However, when it comes to drug discovery, I do believe that the existing paradigm has hit the wall. It's just that because the process is so long, we're just feeling that the fact that we hit the wall very slowly. We're just not sensing it, but we have hit the wall. We need to go over that wall, and then AI is going to actually help us. Now, one thing about drug discovery is one thing because we're still working with the molecules up until the last minute. But then healthcare, general healthcare, is all about the patients, and then of course we cannot run experiments with the patients or then patients are us. Every single one of us gets sick at one point. Thereby, we are all patients ourselves. So that's the reason why these kind of wearables are really important. All those measurements are really important. So trying to track how the individuals are evolving over time and then trying to be as preventive as possible is one thing. So I'm Glenn Debris, professor of health statistics. I got this endowed chair about a year or so ago. And then Glenn DeVries, who actually unfortunately passed away a few years back by accident, he actually founded a company called Metadata. And he's been very, very into this kind of how to make healthcare more data driven. And then he wrote one book before he passed away called The Patient Equation. This is one of the kind of, let's say, easy to read book for the public and also still give the public the sense what we can do if we can actually collect more data and then do a better, let's say, processing of the data in order to provide a care to the not patient but everyone. So, yes, so I think that we are getting there. It has to be done slowly, but the baseline, the current status is actually not that great. It's getting worse and worse. So we have to do it despite the fact that it is going to be very difficult.
So, I'm so fascinated by healthcare. I don't care if we spend the whole episode on it, to be honest, even though there's other topics. It's just, I've been involved so I have both my family who's in the hospital for different but serious reasons. One, with colorectal cancer, which they just got removed, stage 2, they're clean, everything just went home, so that's a miracle. And then a less good outcome, a mom who had a foot infection that lasted like 15 years, and she finally
Oh,
it tried to infect her spines. They amputated her foot at her
oh,
request. Yeah, and so now she's figuring out how to live with, a wheelchair and a prosthetic. And so as I've caregiver trained and in physical
yes.
therapy with her and
Mhm.
all this stuff happening to me, and I have been unfortunately given a crash course on this stuff.
Yes.
So, one thing, and this is one where when you talk about aiming towards collective populations, most of, and I would claim even for my parents' case, you can trace back their problems to the traditional problem in America for most healthcare, which is people eating too much.
Mhm.
Metabolic syndrome is what they call it, which is what
Yes.
heart disease and diabetes and everything else
Mhm.
comes from. And I'm looking at GLP-1 drugs, and I am like,
Yes.
we need to give that stuff out like candy. Like, I want like massive, I want like programs. I know there's like memes about it too, where like people will like do memes in the other direction to
Mhm.
do like
Mhm.
weird new types of body shaming, which is hilarious in its own way. But like the main thing is, do you agree with this? Because a lot of people will say, well, what about the side effect? And I'm like, have you seen the side effects of not being overweight? Like, have you seen? I've seen them, and I'm
Right, right.
curious your thoughts on this stuff.
Yeah, GLP-1 is fascinating. Actually, its history is even more fascinating because we've known about the importance of the GLP-1 receptor for diabetes from 80s. And it took us like, what is it, like 40 years to figure out and approve a drug that is based on the GLP-1, let's say GLP-1, to treat this kind of weight loss as well, or the overweight syndrome, right? This is really fascinating. Now, what is really interesting about GLP-1 as well is that in fact, probably, I don't think anyone knows for sure with the 100% confidence is that it's not working because what we thought, how we thought it was actually working for, let's say, weight loss. It's likely that it's actually acting on our brain So GLP-1 receptors are not only in our gut, but also in our brain as well. And then I think that there are growing pile of evidence showing that it actually works in the GLP-1 receptor in our brain. Thereby, it actually does change the behaviors of the people as well. But extremely fascinating. And then this also tells us about the why drug discovery in healthcare is difficult. And then we have to embrace the uncertainty because we have a extremely high uncertainty about how this drug works. But we're just prescribing, like as you said, candies at the moment, right? Now, is this a good thing? I do think that the increasing the access is better, but of course, any drug always has the unanticipated side effects that may not be actually serious, by the way, that may not be serious for individuals, but over time may actually show up. So, in my view, just like what I talked about earlier about this kind of society level clinical trial where I toss the coin every time, we probably want to ensure that we don't give everyone this GLP-1, nor to restrict the access too much, but kind of say mix it in so that we can actually see it at the society level over time, how it affects individuals, society, as well as the overall, let's say, economy as well, because changing behaviors will definitely have a huge impact on the overall economy and society as well. So maybe not everyone, but more people than now, I believe, yes.
Cool. Well, yeah, and the anti-addictive properties, right?
Yeah.
GLP-1s are having like seriously, the more I look at these, I really consider it like the miracle of medical science in my
Hmm.
lifetime. Like more than any one change that I have seen, I'm like, okay, it's a choice now. Not fully, right? But like some of
Right.
I forget the name of it, the one that starts with the T trizepatide, something like that.
Versatile. Okay.
That's like the
Uh-huh.
strongest and best performing clinical form of it for
Yeah.
most people, and I look at that and I'm
Right.
like, "That is just a marvel, that's like going to the moon," you know, given how big of a problem that was, and so it's just
Yeah.
that's where even if it's, like, harder to do drug discovery, and I'll point out that one of my favorite films is called The Andromeda Strain, and
Mm.
book and all that about the whole you have to time travel back to when the fungus you needed was actually there to, like, solve a plague. I'm curious about how you view this, and then also things like the risk of superbugs. I have my own problems. I actually, and
Uh-huh.
this is where I'll get controversial. I think you should that the vast majority of like MR, maybe not
Mm.
MRSA infections, but risk of superbugs is primarily in overuse in agriculture, and that I should be able to
Mm.
get like freaking penicillin if I want to from like my pharmacy without a doctor's note and like
Mm.
I can in Asia in a lot of cases for like
That's
frontline
true.
antibiotics. And so I'm
Uh-huh.
just curious, what are your thoughts on all these things? And yes, I know antibiotics overprescribed, but I don't think the risk is that bad compared to agriculture again, right? But anyway,
Yeah, yeah. I'm at the few thoughts. So, okay, so the more recent, let's say, weight loss drugs, or their variants coming out are not actually targeting just a one, let's say, receptor that is the GLP-1 receptor. They are actually looking at more than one of them. So, can we design a molecule that can target two, if not three, let's say, different targets simultaneously? The GLP-1 is one of them, GYY, and then there are a few of them that GIP, and few of them we can imagine. And then this is a really one thing that makes me somewhat frustrated by this, let's say, whole, let's say, field of the drug discovery is that the choice of the targets is somewhat arbitrary because if we knew really about everything, why didn't we actually design a molecule for both GLP-1, GLP, and GIP from the beginning? Because we didn't know. We just saw that, oh, it works well when we target a GLP receptor. Let's try to go for the other receptors as well. And then some are going to be successful, some are going to be unsuccessful. We actually don't know, but we pretend that we know. I think that's the biggest issue. We pretend that we know. In fact, my thinking is that we should actually simply go for every possible combination of about 20 or so, let's say, targets that a lot of the pharmas and biotechs are, tackling all simultaneously, and then test them en masse. That's probably the better way to go than what we are doing is that we go one at a time, pretending that we know what we are doing, although we actually don't know exactly what is going on anyway. So It is definitely a wonder drug, but this drug is going to evolve quite rapidly over the next few years. And then along the way, hopefully we'll know how to actually control these things better. So not by making one drug and then hoping that it's going to work, but designing the drugs that are much more specific and sophisticated so that it's going to work for the individuals or the some subpopulations at a time much better. And then this connects to all those issue of the controllability. At the moment, what I see with the drugs is that say I have a laptop and then I see that there's some issue. And what I'm going to do is that I'm going to actually trying to pour some water or some kind of substance on my laptop, and then I'm going to run the testing on 30,000 different laptops I have, and I'm hoping that one of the substances that I poured onto my laptop is going to fix this problem miraculously. And then somehow down the road, it's going to fix also other problems as well. And then this is a very inefficient way. It could be made efficient if we do it at, let's say, millions, if not billions of the scale. But doing it only narrowly and then thinking or pretending that we know something is, I think, the worst kind of midpoint we are at. And then hopefully we can actually go to the massive experimentation and a deeper understanding simultaneously there. And then we'll be able to kind of, let's say, let's just aim for weight loss. Let's aim for treating the particular addictions. Let's say maybe in the case of the maybe cigarette smoking we want to target. We want to target for the gambling and whatnot. Because of one weird thing about the GLP-1 agonist at the moment is that it doesn't actually work for the cigarette smoking. People stop drinking, but they still smoke. And then we don't know why that particular thing happens. Maybe nicotine has a different mechanism. Who knows, right? It's a very interesting thing that is happening there. So this kind of, let's say, GLP-1 and so on, absolutely fascinating. Now, coming to antibiotics, there comes a really interesting economic, let's say, issue that we need to talk about. What is amazing thing about the GLP-1 drugs that we see is that their safety profile is extremely good. There are side effects, but relative to the many other drugs where the side effects can be extremely, extremely, sometimes fatal as well, GLP-1 tends to have a much better safety profile that makes it easier for pharmacists as well as the pharmacists to prescribe them and then prescribe the compound version of them much more readily. And then because it can be prescribed to like the large population, Ellen, you're talking about why don't we give out to everyone? That means that there is now the economy of scale. Thereby, the price can come down. But for most of the other drugs, that's not the case. And also for the antibiotic, there comes a weird issue where as soon as there is a particular resistant, let's say, strain of the bacteria for the particular antibiotic, the value of that antibiotic drops very dramatically because you cannot really prescribe that anymore because the particular resistant strain is going to make it a moot point to have it. So what people do, from the, let's say, biotech and pharmaceuticals perspective, antibiotic research or the development is a economic suicide if you think about it, because it doesn't make making antibiotic easier. But antibiotics economy is actually in a shambles because the value is going to just drop off as soon as it's being prescribed quickly and then there are more resistant strain. So often what happens is that the government tends to actually jump in, like all over the world, trying to buy this kind of frontier antibiotics and then save them and then still use it to essentially subsidize the development. But the development cost is only going up and then the subsidy can stay only flat. So that's an issue. Now, this is also where I think this AI is going to be really help us because AI helps us finding better antibiotics or any kind of drugs because it can tell us based on all those existing data as well as the experiments that it recommends, tell us where to look for. And then that's, I think, the superpower that AI is going to give us. And then where to look for is going to be determined based on this kind of end-to-end prediction. Will it be very promising at the clinic? So then maybe once that happens, it's going to change a lot. Genentech has been looking at the AI for antibiotic discovery for many years. There is definitely a progress and the promise that we can see.
What do you think about language models in this for this use case? Like for sure, like in medical, when I'm going to the doctor and like he's just like he recording my
Mhm.
notes and then like some LLM will collect it and analyze it and
Yes.
all these things, right? And maybe right, like if to analyze my case and if I have a lot
Mhm.
of like tags,
Yes.
it can
Yes.
be helpful for sure. But what do you think about drug design? Do you think that we can actually use and
Mhm.
some knowledge that are out there, for example, in the literature, or like to help it analyze or to use these like coding skills, for example, to
Yes.
make more rigorous analysis?
Yeah, absolutely. Actually, on both sides. So perhaps I can start from the hospital side as well. Hospitals, one thing that every clinician is trained like very well on is how to write clinical notes. The reason why they are trained extremely well to write the clinical notes and they spend massive amount of time writing clinical notes is because the whole healthcare is designed so that even if the patient is being, let's say, treated by another doctor or seen by the another nurse, months, if not years later, they should be able to get the same level of the healthcare as if the patient has been seeing the exactly same doctor over the duration. So thereby, the clinical notes is where clinicians are trained to write everything that is relevant to diagnosis as well as the treatments and then outcome of the treatment as well. And then what that means is that the having this kind of language models or the let's call it clinical language models gives us a superpower. So rather than go into this kind of EHR database and then trying to extract out the particular features we believe are going to be helpful for building a predictor, what we now can do is to have this language model read these clinical notes that is the effectively enriched feature set that describe individual patient to make variety of predictions, the prediction model, build the prediction models, and then that can actually include, let's say, hundreds, if not thousands of them. Do we think that this patient is going to stay here for how many days? So length of stay. If we can make a prediction of the length of stay better than random chance, then we can suddenly optimize the entire hospital in order to accommodate more patients and provide them with a better care. Can we actually guess that this patient may be readmitted within the 30 days at the time of the discharge? If it says that potentially, then we're going to look at them once more because any patient who comes back even after they got discharged is a bad sign not only for hospital but for the patient. And then by ensuring that they only get discharged when they should, we actually effectively opens up the future capacity for the patients. So in this sense, these language models are amazing, gives us a superpower. That's the kind of thing that I've been working together with the NYU Langone, especially the Eric Orman, who's the neurosurgeon there as well. Now, on the drug discovery, language model is even more fascinating there. Now, what we actually tried when I was at Genentech until recently is to train one language model that takes us that is trained on the scientific articles, molecular data that we have, all those experimental measurements and so on, and the various developmental data, as well as the clinical trial data and the actual patient EHR data as well. So Roche actually has all those different units in underneath. And then what we could see was that these models are able to make connections across these different stages that in some sense span several decades. So not a single human scientist can actually make that kind of connection because too much of the data as well as a too diverse set of the data sources we get into. And then this language model is how we are actually going to make connections and capture all those correlations. Either causal or spurious, that's fine. We'll actually experimentally validate whether those correlations are causal or spurious, but that exists across all those stages, thereby allow us to back-propagate predicted clinical outcome per patient or the per patient group all the way to effectively to the coordinates of the atoms in the molecule. I think that that's where we are actually going to, and then that's the reason why these kind of large-scale models are very exciting. Yes, it is a great transcription model that actually saves tons of time. So thereby 40% of the time that are being spent on the note taking will be used for the patient. So that's amazing. But one step further, we are essentially squeezing the entire, let's say, 50 years of the, let's say, process into, let's say, 5 years by doing a back propagation across 50 years of the potential, let's say, progress. So yeah, I'm very exciting. That's why I think that everyone is excited about it. Hopefully, the OpenAI, Anthropic, and Microsoft are excited by this because of this reason, rather than just putting out a web app saying that, well, here's the open ChatGPT health. Great idea, great thing, but not sure if that's what the frontier left should do.
So I have a question like regarding the how to say it, how much the data is dependent on how much you need to specialize in the data, right? Like I don't know. When I worked in my BA on like detecting some
Mm.
features in embryos, so like we needed very specific types of knowledge in order to detect, like to understand each one of the organs and things like that. Um, do you think Anthropic and OpenAI, like they can just throw data, throw compute, and get results without knowing the specific field, or do you think this is something that is very like
Yeah, so
task specific?
between 2016 and 18, we spent about 3 years at NYU Langone Radiology to collect the data set called the NYU Breast Cancer Screening Dataset Version 1. And then we really spent a lot of time filtering, cleaning up, and then finding follow-up exams to check whether the lesions that were detected in the breast cancer screening mammograms were indeed, let's say, malignant or benign. So we spent 3 years getting all those data. Now, I think that this is probably the right way to do it, especially if we want to utilize the existing data as well as we can, because the existing data was collected and recorded and maintained without actually taking into account that it is going to be consumed by these AI algorithms or the machine learning algorithms. But going forward, because the thing about any kind of data we think about in the real world is that the real world changes, thereby the future data is always more valuable than the past data. The value of the past data always drops, future data's value only goes up. So what that means is that if we are now in a situation where all these AI systems are being deployed, or at least deployed in shadow as well, so we can, in fact, start with this kind of roughly curated data, as long as there's a large amount of data, with a large model that captures all possible correlations there. We're going to deploy them, maybe alongside the doctors or on its own in situations where that is actually safe, and then you have to be reasonable to do so. And then we're going to use this model to collect more data and then mark which data is more important, which data tells us about the causal relationship or not, and then use that to fine tune it. So in a sense, as Neuralife's Rich Sutton as well as a lot of people talk about the continual learning. Continual learning has been happening for already 3-4 years in the real world, in the wild, essentially. And then we just need to do it in a better way and a more focused way for each of the individual areas, so that we go deep and then collect a much better future data. I think that that's the right way to go about. So in that sense, yes, they are doing a good job, I believe. They just need to now figure out what is the next step. How are you going to ensure that they get a good enough feedback quickly, so that all those past data is going to eventually removed from the whole pile?
Wow. So, there's these connections between language modeling as a task and personalized medicine, DNA, and really a lot of what they do in bioinformatics is honestly the same stuff applied to different domains. And sometimes we're the ones looking over their shoulder, not the other way it's around.
Mhm.
So what do you have any thoughts there? Because I got my dog's genetics tested, and I've been fascinated. It's like, isn't this where clustering gets motivated for, right? Is dealing with like DNA. Like, why hasn't this gotten better?
Yeah, so there are a few things. There is this kind of, let's say, idea that the genes or the effect of the genes are largely linear. That's kind of, let's say, a belief that is, you know, uh, exercised by many of the bioinformaticians as well as computational biologists. And then that has been going on for many decades. Now, there are a couple of the reasons, because it's always a cycle, right? It's not that they necessarily believe that that is the truth, but rather that that actually agrees well with the tools that they have at their disposal. Now, a lot of these linear models, in particular with the sparsity, does get us a large portion of the correlations that exist. So if I have certain type of the symptoms of the patients, and if I have a genetic, let's say, sequencing information, then I would anticipate that the couple of those genes are going to, or that their expression or the mutation are going to tell us about these symptoms, or are associated with the symptoms. Then I can now start from there and then say that, well, which one is the actual cause? Let's try to design a drug or some kind of preventive, let's say, measure there. So that was kind of driven by the tools. But as we actually learn increasingly more so, is that the fact that the 90% or more of the association is captured by the linearity does not imply that the 10% or 5% are not important. In fact, perhaps the more important and controllable signals are often nonlinear, and that exist in this kind of smaller variation that in the data. So now that we now know how to train this kind of highly nonlinear sequence-based models or the graph-based models, now everyone started to see that in fact, there are highly nonlinear and higher order relationships or the functions that are happening across the different genomes, as well as even the environmental factors as well. So that's, I think, the reason how it works. And in fact, it's the same thing with natural language processing and machine learning as well. So when I was working on more on the machine translation side in 2015 and 16, some of people actually did tell me that I wasn't working on kind of core machine learning because I was working on NLP. I wasn't working on vision. I wasn't working on anything else. But then now looking back, in fact, all those the language models or the machine translation systems that were built have become suddenly the core of AI. So in a sense that this is kind of, let's say, what we can only understand well what we see. And then we tend to actually make a mistake that our perception of the world is the truth about the world. And then whenever our perception changes, our thought about the truth of the world also change. So I think that that's what's happening. And then you're indeed right. HLM and whatnot, all those techniques were indeed either independently invented or were invented from the first place in bioinformatics and many of this kind of computational biology.
So what do you think? So two questions. Like first, what do you think now if you have like, I don't know, $10 billion? What do you think is the most urgent or like impactful thing to do? Both in drug discovery and also like
Mm.
in
Oh,
health,
$10
like
billion
general
dollars and
healthcare.
I see. Uh-huh.
And the follow up is like, what do you think will actually happen? In the next, like, let's say 2, 3, 5 years to the field.
Mhm. I see. So the retirement into an island is not an option, I guess. Okay, all
You,
right. I'm going to
it's
skip
also
that one.
possible, but with like a doctor that that look on your health all the time.
Right, right. So there are a couple of things that I think are really important. One is very immediate one is if I had a $10 billion, I mean, if I had just $1 billion, that's fine. We need to actually work much more and then much better on this kind of infrastructure side. Compute infrastructure is indeed becoming a bottleneck for going deep into individual domains at the moment because most of the compute resources are being effectively monopolized by very small number of the highly, let's say, competent, but extremely narrow-minded, let's say, companies in the world, most of which are actually in Silicon Valley these days. I mean, I'm not going to name any of those companies, but I think that we all know who they are. And then what this means is that yes, we are making huge progress, but then the progress is really narrowly defined. And then we are actually missing out on some of the areas, such as healthcare, drug discovery, and whatnot, that we think are going to have an actual bigger impact and touch upon every single one in this society. So if I had a $10 billion, what I would actually do is to build a GPU cloud that are going to be more distributed, but are going to be, in fact, much better priced, extremely competitive, and provided to these startups as well as the companies that are working on other more still narrow, yes, other narrow areas and go deep and let them go deep, like the healthcare, drug discovery, and whatnot. I think that that's the one thing that needs to be done immediately. And probably I shouldn't do it. It should be done by all the governments as well as the big companies all over the world. The second thing is that if I decided to go narrow and deep with the $10 billion, we need this creating a patient in the loop kind of, let's say, drug discovery system. And then I think the technologies are there. We just need to glue together the pieces where some are going to be AI algorithms, like training these big models inference, but also aspects of the causal inference, causal discovery, and experimental design. So black box optimization combined together with the actual healthcare providers. Effectively, what I think needs to be done is that if I had $10 billion, oh, $10 billion is great. Okay, so sounds great. I think I would actually go out there and then buy a hospital network somewhere in Midwest. And then while running the hospital, on that side, in-house development of the entire, let's say, loop that involves the patient, clinicians, lab, and also the AI algorithm that is going to trying to tackle the problem of the let's say, extremely personalized or hyper personalized treatment, let's say, design and treatment. I think that's what needs to be done. I believe that if we put $10 billion over the next 5 to 10 years, we would be able to actually demonstrate that this can be done. From which, of course, the whole society takes over, and then you have to make it into a more standardized protocol. So that's what I think is going to happen. Even if I don't do it, I believe there are people who are at the frontier who are thinking about this. Of course, the Genentech being one of them, but Isomorphic Labs is thinking along that line. And then there are many new generations of the AI for biotech, AI for health startups that are probably thinking in a similar way.
Do you think that and maybe it's a little bit connected to the centralization versus decentralization? You know, I tend to think AI is a winner take most industry, but healthcare hopefully isn't in a sense, right? I mean, and intuitively, I want competition in there. Do you think that it's better to be a smaller company or a bigger company in some sense? I mean, I'm sure most would say bigger, right? But you
Yes.
know, they want more money. But like, do you think that there's more velocity for small startups to outcompete current existing big players?
So there are kind of, let's say, two types of the scaling, right? So a lot of the scaling that we talk about nowadays when it comes to AI is a horizontal scaling. That is, let's make the general, let's say, general purpose, let's say GPU computing, let's scale it up so that we have a very big model that is able to know and then do a lot of things generally well across the different domains. But then, of course, there is an aspect of the vertical scaling, is that even if you have amazing, let's say, ChatGPT or the GPT-like models, if those models never actually get to interact with the patients or never get to interact with the actual experimental devices, thereby interact with the real world, there will always be a limitation to which these models can resolve the spurious correlation from the causal correlation. And then without the causal correlation that is dominating the what is being within these models, whatever comes out of these models will not be actually trustworthy for us to test it out. So what that means is that there has to be a vertical integration that needs to be done, or the vertical scaling. In the case of of course, drug discovery, you need to be able to vertically integrate everything from the science all the way to the clinical trial. And then many of the big pharmas have the ability, I'm not entirely sure they have the will or nor the kind of future-looking prospect to be able to do so. But this is a kind of thing. In the case of healthcare, of course, you can think of it from the patient, health providers, all the way to the payers as well. And then this kind of vertical scaling. I think that this kind of vertical scaling in few domains like the healthcare, drug discovery, even coding included, in my opinion, coding as well as the construction and many of the other stuff will actually be important. And then those places, small companies will start, but rapidly those small companies will vertically integrate. Thereby, they will look like a very big company. But initially, it'll have to be small company because a big incumbent in all those these sectors, like the manufacturing and so on, they unfortunately are very, very behind in thinking about what AI can do for their sector.
I want to
Well,
talk a bit
oh no, you
I
go.
want to talk a bit about like regulation. You know, from American perspective, every regulation is bad. Every regulation is like making the progress slower, right? You don't need it. You need to remove anything that related to regulation. Um, but from other hand, right, we see that the American health system is quite of broken, right? And do you think this is something that like uh, currently, is it good enough? Or do you think that like we need more or less or different regulation, both in healthcare and also like drug design?
Hmm. Yeah. Well, generally, I mean, I just like everyone else in the world, I think the regulation always brings both the joy and the frustration. Often it depends on whether you are being regulated or whether you are regulating others. It feels like. But then perhaps what I can say is that not necessarily for healthcare or drug discovery in particular, but generally about the regulation, because there's a major issue of the AI regulation these days as well, is that there are two aspects that are missing at the moment in this kind of discussions. Who are not missing? Sam Altman is never missing. Dario is never missing. And then all those famous senators, they are never missing. Josh Hawley is never missing somehow. They're showing up at every hearing. And then all those things. Okay, that's great. And then all those prime ministers and so on all over the world, they are never missing. And then all those companies are not missing. And then all those companies that are going to benefit from AI, they are never missing. But who are missing, the first one is the actual people who are going to be subjected to AI. In fact, once the healthcare is going to be dominated by all those AI algorithms, we are all going to be the subject of the AI technology. And then, in my view, regardless of our own, let's say, expertise as well as a patient, as a patient, we have to be involved in this discussion, but we often don't really involve the people who are users and are being subject to AI technologies. You see all those Senate hearings. You don't see the people who actually got hurt by this kind of misuse of the AI technologies, but rather we see all those star CEOs more so. So that's the one aspect that I think is problematic. So we need to try to involve these people. And the second thing is that there's a question of whether the regulation should come before or after when the technology has been deployed for good or bad. And then when it comes to this question, I'm more on the side of the latter. The reason being that I do want to give the chance to legislature to be able to build a very kind of, say, loose, let's say, boundary that will be exercised by the judiciary. And then only when that boundary turned out to be not enough, we should using a legislature's power to narrow slowly, let's say, let to shrink it rather than start with the shrinkage and then trying to increase it later on, because the laws are difficult to change. And then once the laws are there, changing that is going to be difficult due to the existence of the entire societies as a stakeholders in this, in any one of them. So these two are the things that I have in my mind. But of course, this is something that there's no right answer, right? That's the reason why we have democracy and then why we want to involve everyone when it comes to not the development of the technologies, but when it comes to regulating technologies. So this is just my thought as one of the, I don't know, 7 billion people on this earth who have some kind of stake and right to this whole discussion.
So what are the what are your personal next steps? Because having this discussion, I want to vote for your campaign for legislature, but I have a suspicion you're not going to run for office and do more great science. So what's the plan?
Well, so I'm now back 100% at NYU. So I'm going to focus a bit on teaching as well as advising my students. But I am thinking a bit about, what are the ways by which all those things that we discussed, I could actually, I don't know, and some help. So on the neo cloud side, I'm talking to a lot of people in Korea, including the government as well as the companies, to see if there's a way for me to put together the team to build one. On the side of this kind of biotech healthcare, I am indeed talking to a lot of people, but not necessarily as someone who's going to start something, but trying to get the sense of. So I'm essentially in the mode of the landscaping. What is happening? Who are actually looking at things? And more specifically, recently, together with my former colleagues Stephen Ra as well as Kunu Choi, we started to look into what are the aspects of the biotech that is related to drug discovery that can be scaled up in terms of the data generation and that are very, very close to patients. And then we started to study a lot about this kind of organoids and then how organoids can be connected with the patient care directly in order to create this kind of data flywheel. And then with the AI in the middle, we can actually use this data flywheel to make the recommendation, both doing the exploitation and then exploration. But of course, we have to be careful about this one for sure, right? You don't want to explore too much with the actual patient sitting in the doctor's office. So we're discussing about that. But generally, I'm in the mode of the exploration and the teaching, having fun actually, and also doing all those committee work at the university. They did not notice that I was back 100% of time, and then started to put me on all possible committees that you can imagine. I'll be a bit busy trying to make departments here work.
I have a question like related to this. Like, what do you think about this? It looks at all the
Mm.
professors now like starting their own company, right? And you did it like long time ago.
Uh, right.
What do you think about it? Do you think like this is like professors have like, I don't know,
Mm,
advantages in this time, or like do you think this is more,
mm.
yeah, we need to do something very empirically, so let's leave all these people that write papers for the living?
Yeah, I have so many thoughts. One is that I should have made a company idea last year instead of the 5 years ago to raise much more and then had to become richer. But that aside, that's for personal thing. There is a really weird thing that I noticed here is that of course, I'm always very pro, let's say, startups. So I want my students to make a company. I want students to go out there and then contribute to building new startups and whatnot. I do have some of my former students having become entrepreneurs themselves. Like the William Falcon is one of the examples who founded the Lightning, and then now CEO of this gigantic neo cloud. But when it comes to professors, there's a unique advantage that professors have in starting a company is that we are kind of, let's say, trained to think deep and then talk a lot. And then that actually helps because it's actually, there is two aspects to it. One is that because we think a lot, we tend to have a bit better expertise in particular area than anybody else. That helps. And then we talk a lot. And then talking about these deep ideas both help self-motivates and then motivates the team members and others as well. And then this is, I think, the superpower that people actually miss. Everyone goes for all those professors that say expertise in technology or the particular domain. But I think the superpower is more or less on the side of can you actually deliver what the idea behind this technology in a convincing and in a way that is authoritative. I think the professors are very good at it. I think they have a advantage. But the weird thing that I started to notice is that quite a few of the companies or the startups that have just been founded over the past few months, they started to call it Neo Lab, right? They started with the Ilya's company, the Mirror's thinking machines and whatnot, and then nowadays there's what was the name? Flapping, flapping wings, flapping airplanes or something like that. But anyway, okay, so I feel like the name is a bit not serious enough. But that aside, it's not the point of it. And then what I see is that some of these professors crack the code. So what do we do actually daily is that we write so many grant proposals because we need to constantly raise money to support our students and our research. And as soon as the research is over, we need to raise again by writing all those grant proposals. And then this perpetual loop is one thing that I dread about being a faculty member. But for instance, let's say somehow I magically raise $1 billion for this Neo Lab that doesn't necessarily have a product, but just an idea of the direction that we want to pursue. I'm going to simply buy $1 billion worth of the US Treasury bond. Maybe not nowadays, I don't know. The US Treasury seems to be a bit in a shamble, but anyway, bond. And then I get the coupon every year. Let's say 5%. So 5% of $1 billion is more than enough to run a research lab that's going to have a top class researchers counting, let's say 20 to 30 of them nonstop. They crack the code. Ilya, I think, cracked the code that he now can do whatever the research he wants with the people that he wants to work with, using without having to raise any more money until the point at which he actually productized something. And then that's what happened with the OpenAI as well. OpenAI started with the pledge of the donation from Elon as well as a few other people. And then they were just using the money to churn it out the research at the point, but until the point at which they became a product company because they had a product. So in a sense, I feel like these so-called neo labs and the professors who are actually starting these companies have cracked the code for private, let's say, research lab. And I'm very both envious and curious and also, I don't know, confused. Let's put it in that way.
Jealous.
Yeah, jealous. Yes. Oh, yes, exactly. Yes. I
but
would
do you
be.
but do you think like for the long term, like these companies, these AI labs, um, are more than like or like have higher chances to get some product out of it, or like, oh yeah, like we will raise a lot of money, we will do some research for a few years, and then someone will
So the
it will hire us.
answer, yeah, my thought is no. So they won't be able to churn out the products that are going to be very successful, at least not with the existing founders and founding members on the helm. They want to do research, great. They want to do a lot of things. But as far as I can tell, a lot of people, including myself, we have a great expertise in technology and then doing research and even product development as well. But when you have a product, it's actually not only the quality of the product, but you need to push it out there and then make sure that the people use it. And then you need to work together with the competitors to make sure that the competition continues in a healthy way so that the whole pie grows and everything. All these things, I don't think we're necessarily good at this. Very small number of us will be able to convert into that kind of role, and it will do very well. One of the examples is Carl Morris Herman, who used to be at DeepMind, worked a lot on the NLP, and then I've known him for some time. He's now a full-time entrepreneur. He has his own startup called the Reliant AI. Great, but it's very, very rare case. In my view, researchers should do research. Unfortunately, at this point, a lot of things that they want to do are at the boundary between the research and product development. Thereby, they go into the product development side and do the research there because it's easier to raise money. But eventually, when the balance is re-met, they'll all come back to the academia or more of a research-focused organization. That's my belief.
So how do you see
Or
like the
retire. I don't know. Yeah.
to an island? Yeah.
Yes.
But how do you see like the role of the academia in this situation? Do you think like what we actually need to do, or like what you want to do? I don't know,
Mhm.
publish papers, like focusing on uh, develop better products. So like, what is the balance that you see both in
Right.
academia and also like in industry,
A
big industries
Oh,
labs?
yeah. That's true. A university is a lousy place to develop any product, so I highly recommend you against it. Don't develop a product at the university. We are not a good place to be. Our role will continue to be exactly what it has been. It looks like our role has been robbed, but that's just because during the past 10 years or the 15 years, we just had a great time. So, for instance, people like me in particular, I got super lucky. I started my study in machine learning and in particular the deep neural networks right before it got super popular. And then everything got popular, and then whatever we were doing were almost right, like a step behind the productization. Thereby, companies were pouring money, university was pouring money, everyone was pouring money into doing so. So we were just writing papers that should have been actually the white paper that leads to the actual product or the white paper that comes after the product. But because of this small lag that existed back then, for about 10, 15 years, we could do what others had to do in terms of the product development at university, pretending in many part that is some research, that is science, and then we were writing papers. And then we got spoiled. I think I got spoiled. And then we started to have this illusion that we do whatever we want and then we're supposed to pay tons of money. That's absolutely not the case. And in fact, most of the industries that are more mature, you go there, PhDs are tiny fraction of the entire workforce because to make the actual product and push forward, you don't need PhD. You need a well-trained people of the all the ranks that you can imagine. PhDs are going to continue to do their research and write papers, but they are not majority nor the ones to actually make money as well. So it's going to come back to that one. But for now, we all are actually having this illusion that the rework something that we are supposed to has been taken away when in reality that was never actually for the university to do. We just got super lucky. I got lucky, so I'm very grateful about being lucky, but that's what happened. So I think that it's going to just come back to the normal kind of state in few years, if not a couple of decades, and then we'll just continue to do our research because yes, AI is going well, but I think that there are so many things that we want to answer because we want to know, not because AI can find it, that they can do. No, I want to know. There's a curiosity aspect, so we'll continue to do it. I think it's going to be fine.
I agree in general. Okay, we almost out of time. Do you have something that you want to add, that you want to advertise, that you want to say?
uh, not really, but I just want to say that I think it's a very nice time to do research and science. And then, despite this, I do hear from my own PhD students as well as many other students all over the world saying that they feel like they are lost, and then they feel like they lost the motivation to pursue this kind of PhD or the research kind of, let's say, career. And then I just want them to know that I think it's a great time to do research. There are so many exciting things to be found and discovered down the road. And especially this is the right time because we are probably making a huge progress in the industry. What that means is that everyone is going to look for the next paradigm to come out of this kind of university or the research area. So great time to be. So no need to be demotivated. I think it's great time to be even motivated further. Yes.
Okay. Yeah, and with this positive argument,
Yeah.
um, we'll finish. Thank you so much that you joined us
Thank
today.
you.
Thank you. Yeah, it's been a real pleasure to have you on and talk healthcare. It's unfortunately near and dear to my heart now too.
I'm very sorry about that. Hopefully, we'll be able to make the healthcare better altogether, so that there's going to be fewer and fewer people who will actually suffer from the health issues or the healthcare system in general.
Amen.
Yeah. And thank you all for joining us, and see you next time.
Thank you.